In this last video, we're going to compare different national health policies. So every country kind of deviates in its own way, but these are the three broad groups. First, we have the Beverage Model. This is single-payer insurance with public provision of healthcare. So doctors are directly employees of the government. There's very little, if any, cost sharing at the point of service when you see a doctor. Basically, you don't pay. And it has a major emphasis on equity. You see this in the UK, in the Scandinavian countries, in Australia, and New Zealand. Okay, and then we have the Bismarck Model. This is like a compulsory private insurance scheme where the hospitals and the doctors remain privately employed, and they are paid by these private insurance companies, but they have like strict price controls that are set by the government. And sometimes that involves negotiation between doctors and hospitals and the government. It's kind of meant to be a balance between equity and liberty. So Germany does this, Japan, Switzerland, and the Netherlands. And finally, we have the American model. This one has a heavy emphasis on private markets. There is no mandate for insurance coverage. There was under the Affordable Care Act for a few years. It's been eliminated under the Trump administration. There's also no price controls set by the government. There is public insurance for select groups, people above 65 who get Medicare, and then people with low incomes. And so the emphasis is on kind of a notion of liberty. It's kind of unique to the US. So other countries really don't have this system, although some did, especially prior to, like in the earlier half of the 20th century. So how do we compare which one of these policy systems is best? One way to do that is just looking at prices relative to outcomes. So on this graph, the US is pretty far to the right. Well, it's the furthest to the right, which is measuring health spending per capita. But it's below the kind of the pack in terms of life expectancy. It's not a lot of health being achieved per dollar, but this doesn't actually provide a meaningful assessment of equity for how that is distributed among the population members. So we see that in the US, we're kind of like achieving less health for a given amount of money. But what if, we're just sicker as a country? Or what if, let's say, different countries value health differently? And what if inequality, it differs between those countries, and then that's what's actually driving the health outcomes as opposed to the health policy system? So if countries differ along these in these ways, then that graph isn't totally sufficient in being able to say which health system is the most effective. So looking specifically at, whether these different countries are at their health production frontier. So it's possible that people in the US just have totally different populations with different inherent health states. So like, let's say the US is just sicker, for example, than another country. Just directly comparing the health outcomes is kind of associated with this first graph on the left. So comparing the UK, the US, and Switzerland, and we can see that the US has less health. Does that mean that they're below their health production frontier? Like they could have more health if not for their inefficient healthcare system. Or perhaps the US is actually on a different health production frontier, and as a result, maybe they are maximizing their possible healthcare outcomes, and their healthcare system isn't necessarily, an inefficient use of resources. Perhaps that's just the most health we can get. Like maybe we're just sicker. And that would be kind of illustrated through the second graphic, where we just have a different health production frontier. It's a way of explaining that concept using the economic theories that we've been talking about in this class. Okay, maybe we have different preferences for health. So let's say that it is productively efficient, meaning you're on the boundaries of your health production possibilities frontier. But that doesn't necessarily mean that that country is still optimizing the way that they're allocating their resources. So perhaps you are productively efficient, but maybe not allocatively efficient if you're spending too much money on healthcare. Maybe those other countries, in fact, are spending too much on healthcare, and they should be putting some of that money towards education, the military, as we do in this country. If that's the case, then shifting money away from health into other things would actually be the more efficient thing to do, as opposed to having so much health as some of those countries have. So in conclusion, public policy can address some of the problems of information asymmetry, but cannot solve all of these problems simultaneously. Countries that with policies that address adverse selection, for example, now face a significant challenge of controlling moral hazard, and it's difficult to do that while still pleasing everybody. By contrast, in the United States, a large segment of the population is going to be without health insurance coverage, in part, or either without insurance coverage or without adequate coverage, in part because the healthcare system in the US doesn't fully solve the adverse selection problem, and instead kind of maximizes avoidance of moral hazard. So we're going to be looking more closely in the following weeks at each of these health policy systems and the kinds of trade-offs that are necessary in thinking about our own values and how they align with these systems.